The last sketch was all about cirrhosis. In the following videos, we're going to show you how we got there. The big ones we'll focus on are alcoholic and non-alcoholic fatty liver disease, in addition to metabolic syndromes, namely hemochromatosis and Wilson's disease. And in case you can't tell, we're at Muscle Beach, in sunny Los Angeles. It's the perfect place to discuss hemochromatosis. Why? Well, hereditary hemochromatosis is an autosomal recessive disorder of iron overload that results in increased iron deposition in places like the pituitary, heart, liver, and pancreas. That's right, we're pumping iron. And when these patients start lifting above their weight class, all kinds of things can go wrong. Hemochromatosis occurs mostly in middle-aged men in their 50s. Women who get the disease are usually 10 to 20 years past menopause. Way later. That's because excess iron is usually lost during menses, pregnancy, and breastfeeding. After menopause, however, all that extra iron starts to build up, and the symptoms of hemochromatosis start to rear their ugly head. We make the distinction between hereditary and secondary causes of hemochromatosis because iron overload can be an acquired condition, most commonly caused by multiple transfusions, as are frequently required in patients with blood disorders such as sickle cell disease. First, however, we're going to focus on hereditary hemochromatosis, which has at least 4 genetic variants. The most common type is caused by a missense mutation in the hep5 gene on chromosome 6. This is a recessively inherited mutation, by the way, represented, as usual, by our shy recessive kid. All those scary thunder thighs and side cheeks. I'd be scared too. To remember the name of the hep5 gene, just think of H for hemochromatosis combined with Fe for iron. To remember chromosome 6 specifically, just think of the outrageous six-pack on this fit lady over here. So firm. Like mutton. And it's not just anywhere on chromosome 6. For a long time, we've known that the hep5 gene is tied to the HLA-A3 locus on the short arm of chromosome 6. So up on the sign, we've spelled out the exact location of this legendary outdoor gym, highlighting the letters HLA, A, A, A. That's HLA-A3. All right, I'm not convinced. How does an hep5 gene mutation cause excess iron to deposit in the body? Well, total body iron is normally tightly regulated, and this process will be covered in much more detail in our anemia series. For now, all you need to know is that iron that's absorbed from the diet doesn't enter the blood right away. It sits in the enterocytes of the intestines until the body says, "Yep, more iron, please!" And then iron is transported from the GI cells into the serum for use and storage in the body. If your body doesn't need iron, the intestinal cell eventually sloughs off, and voila, you poop it out. What if those intestinal cells don't wait for the signal? What if they just send iron right on into the circulation, even if your body doesn't need it? It turns out that enterocytes expressing this mutant hep5 protein will do just that. Absorption from the GI tract is upregulated, and there's nothing you can do to stop it. This is depicted by Braden over here, as the iron weights dig into his midsection, right in the intestines. Come on, Braden. Push it up. Push it up. Come on. This is nothing. You're nothing. Okay, this isn't helping. Iron absorption from the GI tract isn't the only thing upregulated. Notice that the bar holding the iron weights is labeled transferrin. The loading of iron onto transferrin, the major iron carrier in the blood, is also upregulated. This is how iron gets to circulation and starts depositing in the tissues. Normally, with all this iron coming in, your body would tell the GI to stop. Specifically, it's the liver that sends the message. When the liver senses iron overload, it releases the hormone hepcidin, which acts at the GI tract to halt absorption, and acts on macrophages to impair their ability to release stored iron into the circulation. So, because hepcidin locks away iron, keeping it stored, we symbolize it with a key. Think of it this way. Hepcidin locks iron inside cells and out of the circulation. In this case of hereditary hemochromatosis, the liver just can't sense the iron. That's why this spotter here, with the liver-shaped fanny pack, is unresponsive to Braden's iron overload. He's distracted. An unresponsive liver means low hepcidin. as depicted by the hepcidin keys low on the ground. To put it simply, nobody is telling the GI tract to stop absorbing. Like we mentioned earlier, when the body is overloaded with iron, it begins to deposit all over the place: the liver, pancreas, skin, heart, pituitary, joints. This is the liver chapter, after all. So let's start there. Iron takes many different forms in the body. Inside of cells, it's stored as ferritin. Around the circulation, it's bound to transferrin. See those golden granules of sand, though? In the setting of iron overload, iron deposits in the liver and other organs as hemosiderin. Hemosiderin is composed of iron bound to ferritin and denatured ferritin, and is classically described as golden yellow granules seen in the cell cytoplasm. So just think of this golden hemosiderin sand. Since iron is very easily oxidized, excess iron leads to the creation of hydroxyl free radicals in the body, represented here with a spray of oxidizing sparks. Iron may also directly interact with DNA to cause cell damage. When the liver tries to heal itself, you end up with collagen deposition and scarring. So, as depicted by the fibrous liver tree, what you're left with is a fibrotic liver. 60% of people with hereditary hemochromatosis develop irreversible cirrhosis, which is always represented by a big, stony, scarred liver. As a result, these patients have an increased risk of hepatocellular carcinoma. Hereditary hemochromatosis has a convenient nickname that can help you remember a couple aspects of the presentation. It's called bronze diabetes. The bronze part refers to the iron deposits in the skin that increase melanin production and cause a bronze-colored hyperpigmentation. Bronzed and glistening, with shoulders the size of man heads. When iron deposits in the pancreas, patients also develop diabetes mellitus due to beta islet cell destruction by free radicals. At Sketchy, insulin resistance and increased blood glucose is represented by elevated glucose candy. Kinda like this delicious-looking barbell raised in the air. On top of that, as damage to the pancreas progresses, there goes its exocrine functions. Consequently, patients develop steatorrhea and malabsorption from the lack of pancreatic digestive enzymes. When iron deposits in the myocardium, say hello to cardiomyopathy, usually characterized as conduction disturbances and heart failure symptoms. Hemochromatosis may lead to either a dilated cardiomyopathy or a restrictive cardiomyopathy. Head over to the cardio unit for all the details. For now, just think of this dilated heart punching bag alongside this badass heart tattoo. Restricted, if you will, under the mesh tank top. It's like this guy got up in the morning and was like, do I wear the brokini or do I flaunt my rock-hard nips? Wait, why not have both? Iron deposition in the anterior pituitary leads to decreased sex hormone production and a secondary hypogonadism. That's right, you gotta lay off that pituitary, son. I told you there'd be side effects. Last but not least, patients with hemochromatosis can develop degenerative joint disease because iron deposition in the joints kicks off a process called chondrocalcinosis. Next, let's look at iron studies. Serum iron, transferrin saturation, and ferritin levels will all be increased in hereditary hemochromatosis, whereas total iron binding capacity will be decreased. Let's go through these quickly one by one, putting emphasis on the important findings. First, serum iron and ferritin levels are increased. Makes sense. Increased serum iron means more is floating around in your blood, and increased ferritin means more is stored in cells throughout the body. These two are easy to connect with a state of iron overload. How about transferrin saturation and total iron binding capacity? Total iron binding capacity is low. Remember, iron likes to bind transferrin in order to travel in the blood. A low binding capacity, therefore, means that there isn't as much transferrin available for binding. Yep, when the body senses that iron stores are full, the synthesis of transferrin is decreased, in an attempt to decrease the iron transport to the tissues. So less transferrin, less binding capacity. How about transferrin saturation? Well, as you would guess, with less transferrin floating around, all that extra iron is going to saturate all the transferrin molecules pretty quickly, as depicted by the saturated transferrin barbell that just can't hold any more iron weights. Transferrin saturation is the best initial test for screening a potential bronze diabetes patient. If the transferrin saturation is over 45%, you should start to suspect hemochromatosis. Hereditary hemochromatosis used to be confirmed by liver biopsy, as this is usually where the iron deposition is most severe. Nowadays, however, we have non-invasive tools at our disposal. Excess iron deposition may be seen on MRI, and diagnosis of hereditary hemochromatosis is usually confirmed with genetic testing for that mutated HFE allele. If you were to get a liver biopsy and take a look at histology, you'd see iron deposits take the form of those classic golden granules of hemosiderin that we discussed earlier, that golden hemosiderin sand. These granules are found in the cytoplasm of periportal hepatocytes, and they stain blue with Prussian blue stain. Hence the 90s William Wallace blue face paint. As damage to the liver progresses, fibrous septa start to form, and eventually you'll see all the classic histological findings characteristic of cirrhosis.